On behalf of the Community Health Council of Lebanon County and St. Luke's Episcopal Church, I want to welcome you all and thank you for coming out here tonight. We are thrilled to have Dr. Lawrence Sinoway here from Penn State Health. I'll get to Dr. Sinoway's bio in just a minute. When Nikki and I were talking through a speaker for Mental Health Month, the issue of America's isolation epidemic quickly came to mind. And she reached out to Penn State, and Penn State very quickly put us in contact with Dr. Sinoway, so we're grateful that he has been able to come down to Lebanon. I can't tell you how many times here since the pandemic people have noticed what it is to emerge after the pandemic and come back together. And I think we all have stories of what life was like in those couple of years where we found ourselves isolated. I can speak firsthand of what I saw of my aging grandparents and my own teenage children, and what that isolation did to them during the pandemic years. And despite everybody thinking they're connected via electronic device, it's really not the same as compared to human interaction face to face. So, what I think we're going to learn here tonight is it not only manifests itself in mental health issues, but also physical health issues. And most importantly, what I'd like us all to take away tonight is what we can do by way of a community, be it a church community, be it a community center, be it just a community at large, to counteract the isolation that so many members in our community are feeling. So I am thrilled to welcome, as I said, Dr. Lawrence Sinoway, who is the director of the Penn State Clinical and Translational Science Institute, where he guides the Institute's research and infrastructure, and particularly their focus on their work around diseases of despair. His work has been funded through the National Institutes of Health since 1987, and he was named an established investigator of the American Heart Association in 1992. 10 years later, he received the Doris Duke Innovation in Clinical Research Award. He was program director of an NIH program project grant on peripheral arterial disease, which was recently submitted for renewal. This is probably dated, so probably not too recently on that front. But he also authored more than 200 research publications and more than 200 abstracts. He was also part of Penn State's College of Medicine. He has mentored more than 30 medical students, 12 cardiology and pulmonary fellows, 17 postdoctoral trainees, and 2 predoctoral trainees. He served as program director of the General Clinical Research Center, later the College of Medicine's Clinical Research Center from 96 to 2011, and his efforts were instrumental in Penn State's Clinical and Translational Science Award that they received in 2011. Since then, he has been the principal investigator and director of that institute, overseeing its growth across Penn State, including in the areas of informatics and clinical research support. Dr. Sinoway can explain what those things are, because I cannot. He joined the Hershey Medical Center in 1984 after completing his cardiology fellowship at Bronx Municipal Hospital Center and the University Hospital for Albert Einstein College of Medicine, and he completed his internship and residency in internal medicine and was chief medical resident at the same organization. He received his medical degree from the New Jersey College of Medicine. So I welcome Dr. Sinoway, and thank you for coming to Lebanon.
So I want to thank you for that very gracious introduction. What Steve said really just underlines the fact, I think, that I'm old. I've been at Hershey a long time, and I trained actually in the Bronx as an internist and then a cardiologist, and came to Hershey in 1984, and was interested in why people don't pass out when they exercise. Because, you know, when you exercise, you need a lot of blood flow, and your blood vessels open massively. So it was really interesting to me that we could actually stand up and not pass out. And we could exercise, and we would have perfect matching of blood flow to the exercising limbs. So I became interested in the circulation, came to Hershey to work with Bob Zellis, who was a world-renowned cardiologist, and started to do clinical research there. And over the years, I continued to do that work, and then at the late 90s, we developed a general clinical research center, which is infrastructure to do research. And I became involved with that, and then the CTSA grant. And my interest in loneliness and isolation really came when we were looking to renew our grant in 2016. And we were seeing a lot of patients in the emergency room who had alcohol-related liver disease and suicidal attempts and drug overdoses. And there was a paper that appeared in 2015 from two economists at Princeton, Case and Deaton, and they described this explosion of these types of diseases, and they used the term diseases of despair to describe these entities. And they felt that this was more common in small towns than in large places, and was in part related to the decline of industries that occur when you have one big company or type of product within a small town. With economics, eventually that company is going to decline. And when that happens, the workers are disenfranchised. And people who are not able to move and go somewhere else remain in those areas. But because that company is gone and the social infrastructure and the tax base declines, the things that are needed for people decline. And it struck me that at Hershey, we were seeing diseases of despair, and that we were just emblematic of Case and Deaton's description, which was based on national data. So we started work with Highmark Insurance in 2016 and established a really good collaboration with those people and used their data set to try to understand diseases of despair. And we found that over a 5 or 10-year period, diseases of despair were absolutely exploding in Pennsylvania. And it wasn't entirely clear to us exactly why this was occurring. We knew it was related to downturns in the economy. We knew that people who had social determinants of health challenges, either food insecurity or difficulty with housing or utilities or a series of things like that, they were predisposed to these diseases. But one factor that seemed particularly important at that time to us was loneliness. And this was pre-COVID, was the idea that society was changing and that the infrastructure that had developed with face-to-face interaction, as Steve was just talking about, was declining. And people became slaves to devices. And people who worked with devices all the time were particularly challenged. And young people who were just reaching maturity and coming out of puberty, they were challenged because they had to deal with all these things in school, not being, not feeling they're part of the group, et cetera. And so they were predisposed. And we saw loneliness as a particularly important issue. And there was a colleague of ours who was a professor at University Park, and his name was Dr. Feinberg. And we talked, and he sent me a whole bunch of articles about loneliness. And he had studied it for decades. And it was pretty impressive that when people are isolated, things change. They don't take care of themselves. They develop other diseases, and it's really a very challenging path. So in this talk, what I wanted to do was just touch on some of the issues that are particularly germane to this topic. So there are two terms to understand when you talk about social isolation and loneliness, which is sometimes referred to as SIL. It's this combination. It's not just the social isolation, it's also the loneliness. And they're not exactly the same. When people are socially isolated, they're predisposed to becoming lonely. But not everybody becomes lonely when they're socially isolated. Someone could be lonely in a room full of people or in a community full of people. So they're not necessarily the same thing, but they're both bad. And they both can lead to challenges down the line. There are many pieces of evidence that social isolation is getting worse. And yes, COVID was really the cherry on the top. But these things have been going on for a while, even before that. And the information that exists out there is that people are just spending more hours alone. There's less family engagement. There's less companionship. There are more single-person homes. There's less engagement with friends. And there's just less socialization with other people. And there's a decreased sense of community. One of the things we studied with diseases of despair were perceptions of communities about why we're having these diseases of despair and loneliness. And people talked about loss of jobs and loss of infrastructure, but decline in family was a major thing that people discussed. And I think that is one of the major contributors to this crisis. And there are many factors that shape whether you're going to develop social isolation and loneliness. And these can be things related to your medical condition. People who have chronic illness and can't walk normally and are disabled, they spend more time alone and are challenged. People who have mental health issues have problems with interaction with others, and this only accelerates the mental health problem and leads to accentuated loneliness. And there are many factors that contribute to factors that are associated with poor social determinants of health and loneliness. And these are community issues, communities that face challenges, communities that don't have an infrastructure. And one thing people have talked about in the literature is the need in a community to have the go-to person. Doesn't matter if it's the barber or the street cleaner or the guy at a religious figure or a political figure, but communities need that concept of the one person who's there to look out for them. And that is something that the people who work with Appalachian research have really emphasized, this idea that When you want to make things better, you got to find out who those 2 or 3 leaders are in that community. And, you know, an important thing in this problem is the need for empathy. You know, we live in a society where the whole country is becoming New York. You know, people talk about how you pass someone on the street and they don't look at you. And there used to be this perception that only existed in large urban areas, but I'm not sure that's the case anymore, and I think COVID may have something to do with that. So the lack of social interaction that has been seen, I think, contributes to the loneliness. And the quality of relationships people have, I think, has been influenced by COVID. When we're on the phone together or we're on a Zoom meeting together, we basically never see each other. And Miss Monk and I have been working together at Hershey for a couple of years, and we've never met. Tonight is the first time we've met. So, you know, I very much enjoy interacting with her on Zoom, but I think it would be better to interact face-to-face in person. You can work things out better when there's no mute button and there's no camera you can turn off. So the quality of the interactions has been greatly influenced by COVID and by technology. And you know, there are problems that have existed in society before COVID. Clearly there is inequity. And whether or not you feel there's structural racism, there clearly are differences in how people perceive their life and how they feel when they walk down a street. And I don't know how any individual feels about structural racism, but I know that there are many people who feel they're not getting a fair shake. And I think those people are predisposed to loneliness and the consequences of isolation and loneliness. And as I mentioned, there are certain groups that are predisposed to loneliness. Young adults, those of low income, people who live in rural and small town areas. You know, the infrastructure of community-based organizations varies from community to community to community. And at times of stress, you would wonder if each of these communities has the capacity to basically increase the amount they can do for people who need. And it's very clear that there's no duplication of service, and these types of services are overwhelmed. So I think that people who live in rural and small town areas don't have the infrastructure that people in larger communities would have. They have unique challenges because social services that are government related may not be the same. And so I think that there are particular problems that occur in rural areas and small towns. And I'm not sure this is emphasized enough at the national level, that the problems and the solutions and the challenges faced by people in Steelton or Lebanon are very different than they would be in suburbia or even in large cities. And as I said, people who are of poor health and disabled are predisposed, and obviously elderly individuals are very affected by loneliness. And you know, as we started, Steve was talking about visiting loved ones during COVID. I mean, the amount of isolation for somebody who was in a facility, I'm not sure it could be measured, the impact that had on people, the quality of life, the length of life, and it's just a very challenging thing, and it has not gone away with the end of COVID. Individuals who have individuals who are exposed to technology to a great extent have particular challenges that are related to that. You know, it's displaced person-to-person interaction, as I've talked about. They're also exposed to social media. There's very little good about social media. It's a really good way to see how exciting and great other people's lives are. And very few people, when they look at social media, say, wow, I got it great. It's a way to link, yes, but it's also a way to think of yourself as the other. And loneliness is really about feeling like you're the other. Now, an important issue is that loneliness really predisposes you to a number of serious diseases. Not unexpectedly, it's associated with anxiety and depression, and the differences between loneliness and depression. You know, it's not a distinct, clear thing, but they're certainly linked, and people who are lonely are predisposed to depression as well as anxiety. And it also can affect medical things. So when someone's lonely, it's a state of stress. And when people are in a state of stress, their nervous system responds and adrenaline increases. And the adrenal gland, which makes cortisol, becomes chronically active. And these two factors contribute to this state of oxidative stress and predispose people to worsening blood pressure, to heart disease, which includes heart attacks, and heart failure. And it leads to many other diseases, including diabetes, and people who are isolated and develop malignancies have a much worse time of it. So the loneliness and isolation has many links to physical disease. And in collaboration with our colleagues at Highmark, we've done a review of their claims data. And if someone is lonely and develops heart disease, their risk of death from the heart disease is twice what it is for someone who develops heart disease and isn't lonely. So it's a major factor in how you do when you develop another problem. So, you know, it's not just about isolation and people being down. It's a much larger composite of affecting society. It's thought that obviously it's associated with diseases of despair, which I said before were suicide and addiction, both to alcohol and other substances. And surprisingly, maybe through the atherosclerosis it worsens. There's a great increase in the incidence of dementia. So if someone is lonely and they're elderly, you know, they're predisposed to developing dementia. And if they're lonely and they have hearing impairment, that combination of things really predisposes someone to dementia. And that linkage between hearing and loneliness is real striking and I think underappreciated. When people don't hear well, they tune out. And so someone who's in a conversation with a family member or over the holidays, if they're not hearing well, they're just tuning out. And there's a lot of information that when you tune out, the function of the brain declines. And so the development of dementia is accelerated. So, it's a complicated mixture of things. So I've talked about a lot of bad stuff, but I'm also here to say that, there is hope, and there's always hope to make things better. And I think with Dr. Murthy, who's the Surgeon General, and his emphasis on loneliness, and the greater realization by the entire community, there are structured things that we can do as individuals, as communities, and as health providers for those involved in the health system. And I think the things we need to do are to emphasize individual health and well-being. And this needs to start at work sites and in school. Discussion of exercise and a healthy diet really has to begin early in life. And these things are very much related to development of loneliness later. And also early in life, dealing with teachers who can, or people in school who can talk to you about these challenges is very important. And there's a group in psychiatry at Hershey that are working on mental health using school nurses across central Pennsylvania. And I think that that is, a very important direction to move towards. There needs to be a greater emphasis on the importance of interaction and people having eye-to-eye, face-to-face contact. There really isn't a second method of interacting that's as good. Now, for people who can't have interaction in close space, yes, I guess a visual interaction or a phone interaction is better than nothing. But getting out to people who are alone and having those people who are alone, having a place to go to is really important. And it isn't just that people need to be with people who have the same issues they have. That's important. But it's also important, elderly people, and this is not science right now, but this was, when my mother aged, and you would visit assisted living, the thing that brought the greatest smiles to people's faces were when little kids came in to interact. So having programs where children cross different generations and interact with elderly people, I think, are really an important way to enhance social well-being. There needs to be a greater investment in communities and developing places for people to go, children after school, senior citizens interactions. We need reform of digital environments for children and for people who work in digital environments their whole day. It's very easy to become addicted to devices, and it's a challenge for health. And so we need to really start thinking about this. We need the health sector to become engaged. And you know, there are many government regulations that are occurring now that are telling health systems that they must ask people about their social context, where they live, do they have food, do they have concerns about finances, do they have concerns about living, do they have concerns about the safety of their neighborhood. These are all things that are becoming embedded into health systems across the country. And this is, I think, just the tip of you know, the spear as to what's going to be occurring over the next decade or two. It really is crucial that the social determinants of health become part of the medical process. And medical students learn about this, and doctors are familiar with which patients are lonely and which patients have particular challenges. The greatest surgeon in the world is not going to have a successful procedure or an interaction if somebody is living on the street. So these things have to be taken care of, and they have to be embedded in health systems throughout the country. And there needs to be research on social isolation and loneliness. We don't have great studies comparing interactions or looking at new ways to help people who have loneliness. And I think that that's going to be the future. And it really needs to be part of the next generation. And, you know, there's no substitute for kindness and empathy in individual interactions. And it's no more costly to be nice. And when people get stressed, no matter what type of work they do, they're predisposed to, you know, having a touch of an edge. But one kind interaction at a particular time in your life can be very helpful and make a big difference. When our youngest son, he developed an infection in his hip when he was 12 years old. And, you know, he came to the hospital a couple of times before it was diagnosed. And they took him emergently to the OR. And there was a respiratory tech who saw my wife and I on the floor at like 2 o'clock in the morning. And he said, "I don't know why you're here. You guys look really sad. And I'm really sorry. I don't know what you're going through, but I hope it's better." Now, I didn't know that person. It was a random act of kindness. And, you know, that was 25, 30 years ago, and I haven't forgotten it. And I think everybody in this room, there are instances where we have the capacity to have interactions with people and have random acts of kindness and empathy, and that can have a great impact. Maybe not on a whole town, but certainly on that one individual. So we all have a role to play with that type of thing. And from a government perspective, we really need communities to invest not just in law enforcement, but in systems to help kids who are having challenges and to provide services for people who are isolated. So in closing, social isolation and loneliness, a big deal. It's getting much worse. It can affect someone's quality of life, their life expectancy, can affect how they respond to disease, many diseases. And there's something we can all do as people, as communities, as health systems, and the onus is on us to make it better.